Awesome. And then that brings us down to Sherry and Brian. So I'm just going to interject real quick and say I'm going to kind of let you guys take it over from here. We're all here to hear what you guys have to say, not what I have to say. So I'm going to let you steal the show and I am going to mute myself. If anybody does have any questions for Sherry or Brian, feel free to type them into the chat box and we can come back to them later, or however you guys want to run it. It's up to you, but the chat box is available just as a reminder.
All right, very good. Well, thank you, and appreciate the opportunity to connect with you, especially from my hometown. So, Sherry Bryan is with me, and she's Director of Strategic Partnerships at SBAM. And one of the things that we do is organizations can join on behalf of all of their members. So if you're a member of the Ionia Area Chamber, you're a member of the Small Business Association, a premium level member of the Small Business Association of Michigan. And so that means everything that we do is available to you. And so part of it is information, and we do a lot of educational services, compliance education, just staying up on what's changing, what's available. And but then there's a whole bunch of other kind of regular association core services that maybe at the end, if we have a little time, I'll have Sherry run through some of those. But I wanted to give a presentation. First, we'll do a kind of a status of where things are at on the infection wave that we see happening today. And then that ties right into so many of the decisions that get made with respect to business restrictions, what can and can't be done. Is all tied to the public health numbers. So we keep a really, really close tab on what's happening there. Pretty good at extrapolating where we expect things to go in the near future, so you can kind of plan out for that. And then also vaccines, another big part of, we know the end of the pandemic has a lot to do with reaching herd immunity that will come in two ways. People either contracting the virus itself or utilizing one of the vaccines. And then we'll talk about some of the business issues at the end there, that I expect to come out of that, come out of these things as well. I was going to mention too, before I did, there was, when I moved out of the Capitol 2 years ago, I can't believe it's already been over 2 years, but they gave me the pictures that they had. What they do is they put things on the wall that are kind of personalized to you. So over here is a replica of the portrait of Governor Greene, who is a governor who is from Ionia in the 1920s. And so they had that hanging in my Capitol office. And the new lieutenant governor, who's from Detroit, for some reason didn't want a painting of Governor Greene, so they gave it to me. It's actually just a picture of the painting, not an actual painting. But anyway, he's standing, if you guys know Greenview Point Park, which is in Lyons, that's named after him. It was a stop-off point on his way to Lansing from Ionia. He was mayor of Ionia as well. And he used to hunt out there, and now it's a park. And so anyway, that portrait is taken at the top of the hill looking over the Grand River. And then this painting right back here, you can't see it that well. And that painting is an old picture of downtown Ionia, which came out of the state archives. And it has in it the downtown area. It doesn't actually, Heather, it does not include your store. It's looking toward the Ionia Theater. Let's see, that would be east on Main Street, and like what used to be the Baptist church there. It's a different church now, I think. And then, so anyway, I got all kinds of stuff here. Having a good Zoom background was a good excuse to get my junk out of the boxes and put them up on the wall. So I'm going to share my my screen and just go over some numbers. Oh, actually, Kat, could you authorize me to share? I should have asked that ahead of time. I forgot to. I'll just go over some. It's usually a little easier to go over the numbers with the charts and things if I can show it to you.
I think you should be good now.
Yep, looks good. Thank you.
You're welcome.
All right, so this is where we are at today. And so as you can see, not today, actually, these are from last week. These will get updated tomorrow, so they're a week old. But the you just see this current wave that we're in terms of daily infections is pretty steep. It looks pretty similar to what it was in the fall here, if you look over on this side. And although it does, looking at the numbers over the last several days, it does look like this. It looked like we're starting to peak and level out and maybe come down a little bit. And that trend has continued. So it's a little bit early. You can never tell where the peak is until you're past it and you're looking back at it. But really it does look like we are basically at the peak. Good chance that we're at the peak and it's going to start coming down now, which is good because there's several complicating factors that have come along with this wave. This next one that I watch is more of a predicting factor of when you start to see the percent of tests coming back positive. So there's maybe 42 to 45,000 tests that are done every single day. What percentage of those is coming back positive is a good predictor of when you're going to see increasing infections. Sometimes you don't even really see it show up much in the numbers in terms of the number of positive tests coming back from an absolute standpoint. But when the percentage goes up, you know that the next several weeks is going to be tough. So we saw the percentage get down to about 3.5%, pretty close to what it was at the end of last summer. And but when that started to creep up, that told us that the case level was going to start rising. It's the most important predictor of what's going to happen in the future. Again, if I were to, when this gets updated tomorrow, this chart gets updated tomorrow, you're going to see it level off and start to come down a little bit. The last several days were closer to 14% or 14.5%. So it's some early signs that maybe we are getting past this current wave. Now, what's been driving it is clearly tied to, or in terms of which demographics, clearly younger people now than what we've seen in the past. So you see the legend over here that has all of the age categories. So between 10 and 59 is the majority of the new infections, and that's better, of course, than 60 plus, because the case fatality rate among those age groups is a lot lower than these age groups. But that doesn't mean it's zero. Okay, so you're going to see hospitalizations. We'll look at that next, and you will see fatalities out of these other age categories. It's just they're less than what we see in those 60 plus. Actually, when you're over 80, it's about a 25% fatality rate. And it drops pretty precipitously, especially below 50 years old. So here's hospitalization. Again, last week, we were to look at this right now. Instead of being 3122, it's actually up to a little over 4,000. So hospitalizations are now exceeding by a little bit what we saw in the fall last year, which was somewhat of a surprise because the vaccination rates among the older population that you would expect or in the past have been those mostly hospitalized are pretty high, about 2/3. But there are a lot of other pre-existing conditions that even people that are younger can end up hospitalized, although we are seeing a much lower case fatality rate, much lower death than before, but still hospitalizations. In ICUs and intensive care units, this is where the more serious cases would go. You see that at right here, as of last week, it was 638, but it's up at about 807, I think, this morning when I looked at it. So this continues to increase. The overall ICU occupancy is still in pretty decent shape. These being in Saginaw and Lansing being 86 and 85% highest in the state. It's really not until it gets over, those are, they have pretty good sized healthcare systems in those two regions. When the UP is at 85%, it's much more serious. but it's not really until it gets into the low 90%. It takes a lot of hospitalizations to move it even 1% in these areas. However, it does, at the rate that it's been increasing, if it doesn't slow down soon, then we'll be back at a case where hospital occupancy becomes a bigger problem. In fact, many hospitals actually are pulling back on elective procedures right now just because they need more bed space. Looking at the 7-day average for deaths, this information is always a little bit older because the vital records review takes a little bit longer. But with this, this looks a lot different than before. This curve, and in not only that, but I'll compare it in just a minute in a different chart. But this is kind of well. Let me go back. And when it comes to this this particular statistic, because the vast majority of the fatalities associated with COVID-19 are in populations that are now more than 2/3 vaccinated. No matter how high the infection rate gets, it's difficult to imagine it ever hitting this type of a level like we had last fall, and certainly like we had last spring. So this in the summer, it was pretty low throughout all of last summer. We think that while clearly it's going up right now, there's an excellent chance that it never even comes close to approaching what it did before. Comparing the fall to right now, this blue line is the fall, and the green line is the infection rate right now, day by day. And this is 45 days into the increase. So the first 45 days of the fall, first 45 days of the spring. Before the week before, our current caseload was behind the fall caseload by about 1,500. That has shrunk some. That means that it has started to accelerate now and is catching up to what we saw last fall. For hospitalizations, same thing. Hospital census was 950 patients behind last fall before the previous week. And then last week, it was 550 behind last fall. That means that right now, hospitalizations are catching up. But what is not catching up are deaths. So that means that even though people are getting hospitalized, the characterization or the demographics of the patients being hospitalized today are far more likely to have the most serious complication, which is obviously death. So if we were to look at last fall, hospitalizations and deaths had a 99% correlation in terms of their curves. And so if we were to extrapolate what we would expect to happen based on that, right now, there would be 250 more deaths. So that's the good news, that the vaccines are actually working among the population that has been the most vaccinated. And that is obviously the older populations, 75 plus and 65 to 74. That's 80% of COVID-19 deaths are among that group. It gets to 96% if you go 50 and up. So this is the vast majority. And so the success rate in getting the vaccination rates up in there has clearly had an impact on this, where we already see it lagging behind other waves that we've seen, way behind the spring and quite a bit behind the fall. So that's good news. The now vaccination, of course, is open to everybody here. Pfizer is the only one that 16-year-olds can get. Moderna and Johnson & Johnson, we'll talk about Johnson & Johnson in just a minute, are 18 and up. Comparing it to the US curve looks quite a bit different. This dark line is the US, this blue line is the European Union. European Union is actually going up, but again, that tracks, we're doing a lot better than the European Union with vaccines. And it's probably making a difference in these lines. Usually when Europe goes up, over here, you see in the spring, Europe went up first and then we followed them. In the spring or in the fall, Europe went up first and then we followed them. This time, Europe has gone up first. We haven't really started to follow them yet. Although there are some signs that it is increasing more across the US. And this positivity rate, remember I talked about the positivity rate in Michigan is 16% and starting to come down, it looks like now. In the US overall, it's 5%, but it has increased. It was, it was down closer below 3% actually, and is now 5%. So it's still, compared to these peaks, it looks low, but when it doubles in a short period of time, that's something that you really need to pay attention to. The backdrop of that, though, is that we're doing 3 million vaccines a day in the U.S. So that's quite a milestone to hit. Really, an incredible public health response to develop and administer vaccines in that short a period of time. And I know there might be people on the phone that don't like vaccines, and I'm not trying to challenge or start an argument about that. It's just a matter of it's one of the factors I think it's going to play a big role in business restrictions and moving past those types of uncertainties. So we follow it very, very closely at our association. So I wanted to compare though how we're doing to the rest of the world. Here's Israel way out ahead of everybody on vaccines. No, they left everybody in the dust. They paid top dollar. They had the first. They made really a pretty intelligent decision, I think, was to not haggle over price and just say we'll take the first orders so that we can get the first deliveries. And they just went right after it. They didn't overcomplicate their delivery system by making it, by trying to have the perfect, the absolute perfect rollout of making sure that who needs it most gets it first or whatever. They just, I just give an example of an anecdotal story of how they approached it. They started with their older population, of course, and then they had basically an age-based approach the entire way through, which is really easy to administer. How old are you? That's your qualification. Well, but sometimes you have people that don't show up for appointments, they get double appointments, whatever, get stuck in traffic, and these vaccines can spoil pretty quickly. And so the nurses literally went out into the street, they flagged down a pizza delivery guy, and were like, hey, we've got an extra vaccine, would you come and do you want to get vaccinated? And he's like, sure. So there's kind of an attitude there that really has exceeded by far the rest of the country, the rest of the world. Now, so you got Israel, and then there's a few other countries like the United Arab Emirates, which is not on this list, but fourth and fifth in the world is United Kingdom and United States. United Kingdom, remember, is not part of the European Union. So I got the rest of Europe down here. Europe has really been slowed down by trying to have the perfect decisions on who gets the vaccines, looking at equity type issues. And those are important, but it has slowed them down to the point where they're now experiencing a pretty major wave among almost all of those countries. And they spent an extra couple months haggling over negotiating the price on the AstraZeneca vaccines, which is the primary one used in Europe. And others had a big head start. So even though this number of vaccines administered in the UK and the United States is about equal, the UK has actually excelled in bringing down their overall death rate. Look how high it got. And then it came down. This is per 1,000 residents. And so it got way up here. And then they started just going after vaccine administration. But they made a different choice than the US. And it was a risky choice. And it turns out, looking at this chart, it really paid off. And they went with a first dose. AstraZeneca requires 2 doses, just like Pfizer, just like Moderna. And with Pfizer and Moderna, the ones used in the US. What Britain said was, hey, this is raging out of control. We got this new variant. We've got the whole country on a lockdown that was about what we had last spring. We can't stay like this forever. Our hospitals are overrun and crowded, and we don't have enough equipment and people and professionals and space for everybody. So they went with a first dose priority strategy. So what they said was, we're going to give as many first doses as we can, knowing that actually provides a lot of protection. And then we're going to delay the second dose for 12 weeks when United States is doing 3 to 4 weeks. So Pfizer 3 weeks, Moderna 4 weeks. So that was a risky decision because the studies said the studies only looked at 3 and 4 weeks, and it wasn't because they thought that was best. It was because they wanted to shorten the time period on when they could determine efficacy and safety. So if you study a 6-month booster, it takes 6 more months, right, to roll it out. They didn't want to take that long. So Britain said, hey, we think that 1 dose actually works really well. There's some good early evidence of that. So they went with that. They said, we're going to do far more first doses. Look what happened with their death rate. That was way higher than ours before when they started this. And now it's fallen way down below ours. And the US, which was lower before, going with the full vaccine strategy, right on the original schedules of 3 and 4 weeks, that means fewer people get started with the vaccine coverage. So anyway, I show this not to criticize what the US has done. The US played it safe. Britain took a chance. It really appears to be paying off for them right now. In Michigan, we do see our state, unfortunately, leading the nation. There's several reasons for that. We do have the highest concentration of the British variant in our state. There's more identified cases in Florida, but if you do it by population, our concentration is higher. We have a much more contagious, it's about 100% more contagious, so twice as contagious as what we were dealing with last spring. And that's the prevalent form of COVID-19 in Michigan. Beyond that, we've also seen, our state had more restrictions for a longer period of time. The restrictions make a small difference, but a small difference over a long period of time means that Michigan's natural immunity from COVID-19 infections, the CDC estimates that about 18% of our population has had COVID. In many, many other states, and most other states, it's in the high 20s or low 30s% of people have had COVID. So that means there's more kindling for the fire, if you will, here. And so that has had a big impact as well. Looking nationwide, though, we do see their hospitalizations nationwide that are starting to go up. It looks pretty flat here, but it's a 3.8% increase over 7 days. If you look at just the new hospitalizations, 6.6%. So you got to pay attention to that. That means that the infection level is rising nationwide, and our vaccine distribution is going pretty well. I don't expect it to look quite as tough as what we see in Europe because of that, but still plenty of opportunity as we're showing here in Michigan. How does Michigan stack up with our efficiency in administration of the vaccine? Middle of the pack. So this blue line is the top quartile of states, the top 25%. This red line is the bottom 25%. And here's Michigan smack dab in the middle. So Michigan is kind of a mid performer out of all 50 states. Our first dose, this blue line is the first dose. This red line is the second dose activity. And then this is both of them together. In the last week, this has shot up over 100,000 shots administered per day on average. So this line, when I do these charts, the updates tomorrow, it'll show them continuing to go up. But that doesn't mean new people are getting vaccinated, because half of them are second doses for those that have already been vaccinated. If we compare ourselves, Michigan, to just the top 20 largest states by population, Michigan is, whether you do it by total doses administered or percentage with the first dose, we're lower middle, so third quartile of states. So a couple issues, and then I'll pause here and we can have a discussion. The Paycheck Protection Program Draw 2 is likely to run out of money by the end of April. So probably you've already either gotten it if you qualify for it, or you've made a decision that for whatever reason it doesn't work well for you. But if you haven't yet, or you're still on the fence, or you're not sure, it probably will run out. It might make it a little bit into May. Technically, it expires on May 31st, but when it runs out of money, it'll be done. Workplace safety rules will be extended tomorrow. This is kind of a controversial thing, but not unexpected. So it's different than the emergency orders that put restrictions on, like indoor dining and all that stuff that we've been dealing with for the last year. Workplace safety rules are the ones that say that you have to do health screening, that people have to wear masks. It's the regular MIOSHA workplace safety rule process. And those rules are done 6 months at a time when they put new rules in place. So the fact that those are going to get extended for 6 months was not unexpected for those of us who know the Administrative Rules Act, because their only options were to have no workplace safety rules or extend them for 6 months. A shorter term extension is just not one of the options available to them in the law. I do expect they will modify those. The main issue that in those workplace safety rules are the ones that say any work that can be done remotely must be. This means that office workers are supposed to be working remotely, and there's a lot of reasons why that causes problems with respect to ripple effects across the economy. Because even if you can do the work remotely, when people are working in different places than before, all of those ancillary business services that serve office workers are impacted as well. And so those are kind of the forgotten businesses in this pandemic that, they weren't directly restricted by and operating by the government orders, but because their customers were restricted, in other words, office workers. So think if you're like a dry cleaner, or if you own commercial office building or janitorial services, or if you have small retail or restaurant that is mainly there to serve office workers, and it's just especially going to be in like downtown areas, big to small. I mean, even like downtown Detroit, those retailers and restaurants that are normally have tens of thousands of office workers that are coming into the city, there's only a small fraction of that actually happening now. So so that's a big part of these workplace safety rules that we're looking to get changed, to put it in the hands of the business to decide when and how to manage their workforce. We know that a lot of them are still going to do remote work. That remote work is something that is here to stay, but it shouldn't be by government order. The Department of Health and Human Services, which are the emergency orders, the pandemic emergency orders, those, the meetings are the big restriction there that remains. I mean, restaurants and bars are at 50% capacity, but meetings are limited to 25 people in person, no matter how big the building is. So banquet centers and conference centers, even though they're technically not totally closed by the emergency orders, as a practical matter, they are totally closed by the emergency orders. And so the technical services and like the sound and lighting and catering services, like those businesses that operate around meetings. And then also, lodging and hotels, like the downtown Grand Rapids area, which relies a lot on conferences, is just hugely impacted still by those orders. So that's really the area. I don't expect it really to change until June, but really the DHHS pandemic emergency orders, the meeting industry is the one that's probably the most impacted still on those, and all of those that serve the meeting industry. In terms of vaccine administration changes, in Michigan, it is open to everybody right now. You can definitely get into, if you don't mind going to Grand Rapids, you can get in pretty easily now at DeVos Place. But there's a couple of things that I think are, there are some changes that are happening, and some that I think are possible. I think it's possible that the CDC will change to a first dose strategy for administration, like Britain did. Now that we have real world data back and we see how effective the first dose is, there is no drop off in effectiveness because you wait longer on the booster. that I think it's possible that the U.S. adopts a strategy like that to try and prevent a kind of a third wave from hitting the rest of the country as it has Michigan. In terms of actual changes, they have recommended to not use Johnson and Johnson, that's the one-shot vaccine, the more traditional type of vaccine, and it's because of there are 6 reported cases of individuals within 2 weeks having a blood clot issue within 2 weeks of their vaccine. Now that's 6 people out of 7 million that have received that vaccine. So I was a little bit surprised. Correlation does not mean causation. Blood clots are not terribly uncommon, certainly more common than 6 and 7 million people. But they said out of abundance of caution, they wanted to study if there was a causation type relationship between that. So that's a change that is literally from just this morning. And the CDC is going to meet, or the FDA is going to meet on that tomorrow and make a game plan. I'm a little bit worried though that people aren't going to trust that vaccine at all, even though I fully expect them to make the determination that 1 in a million, literally 1 in a million, which is what we're talking about here. It's hard to make that connection. The CDC changes, the whole thing about deep cleaning. We've known since last summer that this virus does not travel surface to surface. It's too fragile for that. There's actually not a single case known of surface transmission of the virus. It's aerosols and water droplets, and yet all these rules on hygiene have been this time. The CDC has finally acknowledged that this virus does not spread in that way. Now, good hygiene's good anyway, right? There's not really a downside for good hygiene. If people ought to wash their hands, all that kind of stuff. But the idea of like somebody had COVID, and so now we got to shut down this whole floor and do a deep cleaning. There is no evidence whatsoever that that's called for or effective. And then they finally changed their travel recommendations, said that those that are vaccinated. For a while, they were saying, hey, you should still do everything. Well, I mean, why get a vaccine if you still can't, if you still have to do all the same things? And so they've finally started to acknowledge that there are different recommendations. And the final thing I'll mention is that the state budget is has received a windfall of support. So, when this all started, it looked like the bottom was going to fall out, but it didn't. The unemployment, between unemployment and paycheck protection program, businesses and individuals in Michigan, just in Michigan, got about $40 billion. And so what that meant was that, and most of that ends up in a couple of different ways being taxable income to the state. And because even though they might have made it deductible on tax returns, people are still buying things, right? They're doing things with that money. It's creating economic activity like sales and sales taxes. The state revenue has been flat. It hadn't even gone down. But on top of it, so in other words, the federal government said, we're going to make up state government shortfalls by sending them billions in extra money. This American Recovery Plan will be about a little over $10 billion extra for Michigan's governments, state and local and schools. But the revenues have not declined, with the exception of some of their expenses have gone up, but with the exception of cities like Ionia that have an income tax, revenues have declined. But but by and large, they have, certainly for the state, they haven't, and yet the state is going to get billions and billions in extra dollars to make up for lost revenue that actually never materialized. So our state government is going to be in in the next few years is going to have way more money than it's used to having. We have made some suggestions on things that we thought they ought to consider. We think this would be a good time for to do something big on rural broadband and better connectivity statewide. That actually touches a lot of different areas, a lot of different parts of the economy. State government procurement, more kind of direct local direct local sourcing. It's usually a little bit more expensive to do that because you're dealing with more companies as opposed to one big contract. You have several smaller ones, but we think that could make a meaningful impact. But our biggest recommendation to how we get the economy going at its top potential, it's back to the basics. Essentially get out of the way. I mean, there's no substitute for being able to operate. And so lifting as many restrictions as quickly as you safely can. And then on these things like the deep cleaning requirements, just get rid of those. Don't take so long. Once we know that in the beginning, you could forgive it because there wasn't a lot known. And so you got to be extra careful. We're a year into this and we do know a lot more than before. And some of the stuff that we did in the beginning didn't really make any sense. So backing off on some of these extra rules and regulations and also allowing more of the activities like the meeting industry, for example, to take into consideration the square footage that they have available to them. A hard cap at 25 people is not reasonable when you've got really large spaces. Why do they have to be limited to a hard cap when everybody else, retail or restaurants or whatever has they can take into consideration the space that they have. So those are some of the things that we're really that we're focused on in the advocacy front. We are strategically bipartisan, so we're very intentionally bipartisan. It comes natural for me anyway. It's actually probably why I lost that election in 2018. It's not in style anymore, but we do think there's a best governance practice that we work with everybody. And even when we have disagreements, we've had some pretty serious disagreements with the governor, but we still have an open door policy both ways with this administration because we think it's important that we maintain a strong working relationship, and so that we can be that voice at the table for this feedback loop of what needs to change. So I'll pause my comments there, and I'd be happy to take any questions, see what else is on your mind. All right.
Question. I don't know if I should wait. I didn't type anything in.
No, go ahead, please.
So I never thought about what you were saying with the span of time between the first and the second shot. All day long, I get people that come into our lobbies, and it's like a constant thing about people bringing up the whole shots. And the span of time, even with, let's just say with your own children, you have that time, you have the booster shots, and a lot of times people will get them the recommended back to back. But then even with my own children, I do extend that time frame. So your body does have, and I never looked at it as this as being a quote booster shot. So with them, you hear a lot of people, the second shot seems to take a bigger toll on your body. People are getting, a little bit more sick that second shot. It just takes a bigger toll than that first one. So do you think, I'm not saying do you think, but was it Britain that did that, where they expanded the time of it being like 12 weeks? Would that maybe give possibly where you don't have that such a hard impact on your body and maybe not become so sick?
Yeah, I don't know the answer to that, but I do know that because I hadn't read, there's a lot of studying that's happening in Britain right now because they dove in with a 12-week period between doses, and that was a pretty unique strategy at the time. Actually, Florida kind of did but not 12 weeks. I think they stretched theirs out to about 6 weeks instead of the 3 to 4. To get that many more first doses started. But the impetus behind that was not to minimize side effects as much as to get more people that first dose. So, essentially you double the amount for the first 3 months. If you do a 12-month regime, you double the number of people in that first 3 months that otherwise would have received some protection. And it's about 75% effective on the first shot after a few weeks. And so the idea was it's actually an unusually effective vaccine compared to, say, a regular flu shot, which is usually around 50% effective. So even one dose is really, really effective. We'd rather have more people with one dose than half the number of people with 2 doses. And then the whole thing about, but the study said it was supposed to be 4 weeks in between for AstraZeneca vaccines, which those aren't even used in this country.
Right.
It's not one of the approved. They haven't even asked for approval because they can't meet the production needs to add any more countries. But the only reason that the companies studied 3 to 4 is you would never want to do it closer than that, because you're not getting the benefit of a booster if you do them like really too close together. So they studied the shortest period of time that they thought it was possible for them to have the benefit of a booster. It wasn't that was an ideal time, or they expected it to be ideal. But the problem is, you still know what is the most ideal. So it turned out that 3 to 4 weeks still gets you to about a 93 to 95% effective rate, that's like unheard of high effectiveness. And but the idea of waiting longer, it may very well make them more effective by waiting longer. If you just look at other vaccines and how long you wait between boosters with other vaccines.
Okay.
But I hadn't really thought about would it affect the side effects thing, because I have heard that the second, get a little bit of a fever and kind of achy or real tired for about a day after the second shot seems to be a pretty common side effect.
Can I ask another question, or is there other questions?
Let me ask one, Ann, and then I'll go back to you because it's on your original question. So, Brian, if you could explain where the study data is coming on the length of time on the shots. Was it coming directly from Pfizer and Moderna to the state government?
Yeah, the original studies were done in multiple places, but they had, in both Moderna and Pfizer did U.S. based studies, but they had to be done under the supervision of and peer review of universities and bioresearch, and then it goes through a process of review and scrutiny at, in this case, the CDC and the FDA. So it's a pretty involved process, and their review, the oversight, the governmental oversight doesn't start after the study is done. It's through the study startup, the study plan design, the administration of it, the preliminary reviews. It's all done. It has to be paid for and handled by the pharmaceutical company itself. The government doesn't pay for these studies. They require that the companies do it, but they do it under the oversight of the agencies. What was a little bit different on some of the studies this year is that normally you'd want to study on your population within your borders, and that happened with the ones that are approved here. But there was more activity around the world of saying, okay, we've got a study in South Africa, we've got a study in Europe, and we've got and pulling those and using them in other governments, bringing those studies with them for their approvals. And you saw more of that activity this time than before. It just wasn't feasible to do that many studies in that many different countries with a limited number of players in it. But just as an example, the Pfizer study in the US was 40,000 people. So it's not an insignificant number of people in the studies. Now, when they look to, Pfizer is asking now to go to 12 years old so they can do down to 16. The study to add a few more years, those are always smaller because it's a smaller population you're studying. When you're looking at every adult, it comes out to 40,000 people. When you're looking at 12 to 15 years old as a new cohort, that study I think was about 2,600 people.
So I was wondering where they got the study data that shows now that 6 to 8 weeks is just as effective as 3 to 4 weeks.
Oh yeah, so that was in it's actually 12 weeks in Britain. So researchers from all over the world are studying Britain right now because that was such a big chance when they did it. Like people thought it probably is going to work like they think, but who knows? So Britain did it different. So you got researchers from all over the world, and the first one that I saw come out was actually Israeli a research team that did the study on the results in Great Britain. But I also there's other factors too to consider, and that's why I don't. They took a risk and it paid off. The reason that I don't, I'm not down on the U.S. for not taking the same risk, although I think it would be reasonable now for them to go that direction, is because we do have a handful of variants of it. Actually, there are hundreds of variants of this virus technically, but there's only certain ones that take hold and become prevalent. And 2 doses works better on the variants than 1. That was one thing that a recent study in Britain showed, was that there's a trade-off. That the British variant, the B.1.1.7 variant of COVID-19, 2 shots definitely works better than 1 for their variant. It's just they were in such a crisis that some protection for more people was they and their judgment was a better call. So yeah, that in that case, in terms of the effectiveness out in the real world, that's everybody. The stuff before it gets released, that's the company funded, managed, but supervised. The stuff that happens afterward, yeah, the companies study their own stuff, but then it's all open source. Everybody's looking at it. All right, Ann?
Yeah, so I have a question, and I could probably find this out, but you probably will know it offhand. As far as people, business owners that have apartments and houses that they rent out, and under the, you can't evict people right now. When that finally comes to where, okay, you can evict people for them not paying, like I have people that come in all day long and they talk about how, hey, I don't have to pay my rent because they can't evict me. It's kind of irritating to hear that because they're like happy about it. They can afford it right now, but because they don't have to pay, they're just not paying. So when it comes to a point, which it will eventually, where you can evict somebody, does the landowner have to come and say like, hey, you can stay here, but you have to pay all of that back rent? Or is that back rent just null and void and they start from scratch? I mean, how does that work with all that back rent?
Yeah, so they're going to owe the back rent and the back interest and whatever arrangement that they have under the orders that they exist, at least at the orders that they exist today. This is going to be, I'll call it an unintended, but certainly not unforeseen consequence of the non-eviction policy. First of all, that they have a widespread, no qualification required, nobody can be evicted policy is never a good idea. You could qualify it and say if somebody's lost income, then maybe you provide some protections for them. But in this case, people that have lost no income at all, in some cases have received more income, to say that you don't have to live up to your obligations, it's creating a backlog of debt. And they still owe that debt, and I think it is going to cause a big problem. in the future whenever they finally let that provision expire. I don't really know how the public policy makers plan to deal with that. I wouldn't be surprised if it came in the form of another, federal stimulus package where they say, hey, people who have back rent or back mortgage payments, here's some help for that. I wouldn't be surprised if they did something like that, but it is, I just think it has created quite a problem where, as working in financial services, that a lot of people really don't quite understand, hey, if I don't have to pay, I'm not going to pay. And not, just the idea of how much that is setting them back and destroying their credit and creating big problems for them in the future. So,
the part that I'm kind of a little bit baffled by, yes, what you said too, but as in Ionia County, and just working with a United Way, and there's already like a huge amount of people that are either one, homeless, or two, they can never find a place to live, period. And I feel like when this does happen, and there's all these people, not just in Ionia, but throughout the whole state, are going to be evicted, I feel like there's going to be this huge surge of people that are going to be getting kicked out and now no place to go because there's a housing shortage or there's an apartment shortage or whatever.
Right. Yeah. I mean, it will exacerbate that. It'll exacerbate that problem. I mean, there's I don't know where people could possibly, given what's happening out there in terms of the shortage, I don't know where people would possibly go if they lose the place where they're at. It's disappointing that this policy continues. And I think one of the reasons why it does is because they know they have a problem. They don't know what to do about it. So they're just putting it off. Problem is, the problem gets bigger every time they put it off. So we're at that point now. And the thing is, we don't even know how big it is. We don't have a way of estimating how many people stopped paying mortgage and rent. So it could be big.
I have a quick question. Do you feel had about half our staff not want to get vaccinated? Do you see that it will be mandated or for employment to get vaccinated, or rules for that? Or
I do not think that there will be any kind of mandate for people to get vaccinated. And there's a lot of talk about like vaccine passports for certain activities. I think even that is fairly unlikely. There's pretty well established law and case law about not forcing healthcare treatment. So I do think that there's very small chance. Now, as an employer, you can establish rules for customers that come into your place and for your employees. There's some ADA exceptions to that, but by and large, you can establish a policy to require it. But I don't think that there's a good chance that the government will be mandating it. Now, there are places any other time, like when I went to Brazil, for example, in order to come back in the country, I had to get certain vaccines. Traveling already comes with some vaccine requirements. Going to college, when I went to college, I had to show my vaccine records. I'm sure that they will add COVID-19, at least for a while, to all of those kinds of things where there are already requirements. But in terms of like a new one, an employment-based, hospitals aren't even doing it. So I don't think there's a good chance that it would be like a mandate put down on the rest of it. It's too much. There's about a third of the population that they just don't trust vaccines, and it's not like the thing. I'm okay with vaccines. I've already had the vaccine myself, but but that's me, right? I don't. Somebody else doesn't want it. Who am I to say that they got to get it? So we had some work groups with our members just to make sure that my reading of that was correct, and we had pretty clear feedback, like, hey, we don't want the government to mandate, but the top level thing was, we don't want the government to make us the police, the vaccine police. So in terms of keeping track of which employees have had it and which ones hadn't, or to put requirements on our customers, absolutely not. You know, we don't want to get in the middle of that. It was bad enough to be the mask enforcement people. We don't want to be the vaccine enforcement people. So we're still in the process of developing a vaccine policy, but I think that's what it's going to be about is status quo. Employers can make the rules for their own workplaces and for customers entering onto their property, leave it the same. And whatever rules are established in the short term, as we go through this, do not expect business owners or business employees to be the government's police officers for whatever those rules are.
Okay.
That's good stuff. And just to follow up on that, I did send out in our newsletter. If you didn't receive it, let me know and I'll make sure I get it to you. SBM has already provided some guidance on some wording you can use, regardless of whether you decide to mandate the vaccine or not mandate the vaccine for your employees. So let me know if you're interested in looking at that and I can get that information out to you. And it's also available on their website, but I know sometimes it's a little easier if you have the direct link. So I know we're kind of running over on time, but I just want to give anybody, is there any major pressing things that we can answer in maybe 2 minutes or less that anybody did not get a chance to ask? Going once, going twice. Sold. All right. Thank you, Brian, so much for being with us today. We really appreciate the opportunity to get to sit like this and chat with you in a small group setting and get to hear about all of these things that we really just have no idea are going on. So it's very, very informative.
All right. Thank you very much. Great to see you all.
Yes, thank you very much.
And thank you, Sherry, for putting this together.
Absolutely. Thanks, Kat. Appreciate the time.
Thank you all. Have a great rest of your week and we'll talk to you soon.